I always talk about my surgical successes at a year because often we have things that we need to do after the surgery is completely healed.
Welcome back, every Bendy Body, to the Bendy Bodies podcast with your host and founder, Dr. Linda Bluestein, the Hypermobility MD. I'm so excited to chat today with Dr. Andrew Goldstein, the director of the Center for Vulvovaginal Disorders in New York City and Washington, D.C. We know that so many women with EDS, Mast Cell Activation Syndrome, and POTS are impacted by pelvic pain and also perineal pain. This is going to be a really important conversation because so often we're told that there's nothing that you can do that helps. So I really hope that you're going to listen in and get lots of tips from today's episode. Dr. Andrew Goldstein is a board-certified OBGYN. He was on the faculty of the Johns Hopkins School of Medicine and is currently a clinical professor at the George Washington School of Medicine. Dr. Goldstein is the past president of the International Society for the Study of Women's Sexual Health, or ISWISH. Dr. Goldstein has been a grant recipient of the National Vulvodynia Association and other private foundations. He is the founder and president of a 501c3 Maryland nonprofit, the Gynecologic Cancers Research Foundation. He was an associate editor of the Journal of Sexual Medicine, The Female Patient, and Current Sexual Health Reports. He has co-authored and co-edited 8 books: Reclaiming Desire, Female Sexual Pain Disorders, Evaluation and Management, When Sex Hurts, Management of Sexual Dysfunction in Men and Women, an Interdisciplinary Approach, and the Textbook of Female Sexual Function and Dysfunction. Dr. Goldstein is actively involved in research and has published more than 170 peer-reviewed articles, abstract, and book chapters on female sexual dysfunction, sexual pain disorders, lichen sclerosis, vulvodynia, vulvar vestibulitis syndrome, or vestibulodynia, and cervical cancer. I am so excited to have this conversation with Dr. Goldstein today. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Let's get it going. I am so excited to chat with Dr. Andrew Goldstein. And Dr. Goldstein, I noticed that you have been interested, it looks like, in Ehlers-Danlos for quite some time, because you actually published a paper back in 2013 about two case presentations of profound labial edema as a presenting symptom of hypermobile type EDS. And that was quite some time ago. So is this a subject that you've been interested in for a while?
Yeah, I mean, I guess, you know, I've been taking care of women with pelvic pain, vulvar pain, for more than 25 years now. And when I started doing this thing called vulvodynia was this black box where no one knew what it is and no one knew how to treat it. And so for the last 25 plus years, I've been trying to figure out the causes of vulvodynia and one of the things that I've found over the years is both a myofascial component and other components to the vulvar pain and pelvic pain, and recognized again even more than a dozen years ago that hypermobility does play a role. Though I think I'm amazed even more every day how profoundly it affects people with pelvic pain.
And just so the listeners make sure we're all on the same page, can you define vulvodynia for us too?
So the old term of vulvodynia is vulvar pain of a 3-month duration with no known cause. But I don't really use that definition very much because if there's no known cause, that's just means that I'm not smart enough to figure it out yet.
Mm.
And so, really, as I sort of just said, I've spent about 25 plus years trying to figure out the many different causes of vulvar pain and vulvodynia. So it's pretty rare for someone to come into my office and I just say you have vulvodynia. Usually, they'll come in saying I've been told I have vulvodynia, and I'll say, okay, but now let's figure out what's causing your vulvar pain.
Mhm, mhm.
Just like someone, if they come, went to an orthopedic surgeon and they said, "I have knee pain." Well, I mean, the orthopedic surgeon is gonna try to figure out if they have, arthritis or bursitis or torn ACL or torn MCL or patellar tendon or something like that, and so that just, we figure out what the differential diagnosis is. What are the potential causes of pain? And again, that's sort of been my, life's work to try to figure out the different causes of pain.
And so many people have benefited from this work that you're doing because I feel like, so pain in the external genitalia is something that a lot of people have experienced. I know a lot of listeners are already going, "Yeah, I can relate to this," and they may have already seen a gynecologist who says, "Well, you have vulvodynia," but I mean, I I've heard this. We don't know what's causing it. We really don't understand it, and so there's really not much offered in the way of resources. So I think this is such an important conversation to have, and the work that you're doing is really, really important. So we thank you for that because
Okay.
there's there's a lot of people who need this help for sure. So maybe we can talk first about the myriad of ways that EDS or the Ehlers-Danlos syndromes and or hypermobility spectrum disorders, for the purposes of this conversation, I don't think we're going to separate those necessarily. So we'll talk about the impacts of those conditions in general, and also mast cell activation syndrome and how those conditions can lead to pelvic pain. So I know there's quite a few. So if you
Mhm.
could give us some examples of some ways that those conditions can contribute to pelvic pain.
Sure. So I sort of break them up into sort of the three categories of just the hypermobility itself, and then the mast cell component, and the dysautonomia also is again a big role that plays a role in pelvic pain. And just before I start, I actually think um, that the biggest predictor of pelvic and vulvar pain, the biggest predictor is this triad of EDS, mast
Really?
cell activation and dysautonomia, and it really hasn't been talked about because people don't know how to look for it, and really, it's very underdiagnosed. And until I started looking for it, I didn't know. People would, mention their other medical problems, migraines or asthma or eczema or GERD or IBS,
Mhm.
or even endometriosis or interstitial cystitis. I sort of just put those aside a little bit, and I said, we're going to focus on why you're here today, instead of realizing that this is a big, big clue as to why they're here today, or their pot. So really, for the last 3 or 4 years, I've been digging really more and more into this and realizing that there are many ways. So, if we look at just the hypermobility part, one of the things, as I'm sure you and your viewers are aware, is that core stabilization is a big issue.
Mhm.
And so, one way that if you don't have stable joints, and then one of the things is that the way you stabilize your core and your body is by tightening up your muscles. And so, one way people do this is they tighten up their pelvic floor muscles. The problem is if you have hypertonic or overactive pelvic floor muscles, what that does is it cuts down blood flow to the area. That decrease in blood flow causes decrease in oxygen to both the muscles as well as the overlying mucosa or skin.
Mhm.
That decrease in oxygen leads to the tissue living anaerobically, which then causes a buildup of lactic acid into the tissues, which causes burning, throbbing rawness, just like an athlete, just like someone's been running a marathon for 5 years. So that's sort of the most basic way. And I think that was my sort of window into this world of just realizing that tight pelvic floor muscles can cause pain. And one of the reasons people have tight pelvic floor muscles is because they're hypermobile. But that's sort of just the tip of the iceberg, a very
Mhm.
important tip of the iceberg, but just the tip. The second most common way is that people who have EDS and hypermobility frequently have injuries, and one of the most common injuries is labral tears of the hip. And labral tears of the hip then cause instability in the hips. And the only way to stabilize the hips is to have the muscles of the hips go into spasm or to stabilize. And one of the muscles that goes into spasms is the obturator internus muscle. and the obturator internus muscle attaches to the pelvic floor. So, indeed, you'll get hyperactivity or overactivity of the pelvic floor because of hip instability because of EDS. Additionally, that when the obturator internus muscle goes into spasm, it can compress a nerve that goes to the pelvic floor called the pudendal nerve. So the pudendal nerve has branches that go to the clitoris, to the rectum, and the vulva and vagina. And so you can actually get severe vulvar pain, or what people used to call pudendal neuralgia, only because of a hip injury.
Mm.
And you may not even have profound hip pain, but the hip is not stable enough such that the obturator internus muscle is in spasm and it's compressing the pudendal nerve. Not only do you get pudendal neuralgia from compression of the pudendal nerve, and the symptoms again, clitoral pain, vulvar pain, vaginal pain, rectal pain, but you can also get something called persistent genital arousal disorder, or PGAD. And PGAD is this symptoms of just unwanted arousal, and again, that can be, and it's very distressing, and that can again be caused by a labral tear in the hip, causing compression, then leading to compression of the pudendal nerve.
I'm sorry, I just wanna ask before you go on to the next thing, I just wanna ask for a point of clarification. So are you saying with the obturator internus, being, on, hypertonic or being hyperactive, that you wouldn't maybe necessarily even feel that muscle being overactive, you might not feel pain in the hip, but all of the symptoms might actually be in the genital area, in the rectum, the
Absolutely.
vagina, interesting, okay, okay. I apologize. I just wanted to kind of
Nope.
clarify that before we move
No,
on.
that no, no, and it's difficult to to convince an orthopedic surgeon to operate on someone's hip to fix their labral tear of their hip if they're not actually complaining of significant hip pain, but they
Mhm,
actually have vulvar pain. There are a
mhm,
couple ways you can prove it to them. One of the ways is you can do if you do a pudendal nerve block and their pain goes away, and also you can even do botulinum toxin injections into the
mm,
obturator internus muscle, which is Botox. And if you do
mhm,
Botox injections into the obturator internus and the pain goes away, that often can convince an orthopedic surgeon that that is the cause of the vulvar pain. But they're not trained for this, so it's hard for them.
right,
If they're not trained to operate on the hip to fix the vaginal or vulvar pain, but.
right.
But we have colleagues who actually will listen and do that. Uh, the third sort of way the EDS is that, besides having injuries to the hips, you frequently have injuries to the lumbar spine.
Mm,
So herniated discs, annular tears are all much more common. People are hypermobile. And what can happen is a herniated disc in the lumbar spine will actually cause irritation of the nerve roots that actually make up the pudendal nerve.
mm,
So these are the sacral nerve roots S2, S3, and S4. And so you actually can get again vulvar pain, vaginal pain, pelvic pain because of a herniated disc that is, that is much more common in people with EDS and hypermobility. Additionally, when we're still staying at the level of the spine, people who have EDS and hypermobility are more likely to have something called Tarlov cysts or perineural cysts. And these cysts, which lie along the back of the spine, can also impinge or irritate these sacral nerve roots, the S2, the S3, and S4 nerve roots. So that's another reason and way that hypermobility can lead to, and that's just the hypermobility component of it. Um, Sort of continuing the hypermobility component is that people can also have venous insufficiency, and so you can get something called pelvic congestion syndrome because the veins of the pelvis, and there can be a quite rich supply of the veins of the pelvis, they can get dilated, and you'll can get just a fullness or a discomfort, just constant pressure um, in the pelvis because of this venous insufficiency. Again, most likely, that's the EDS can lead to. And again, sort of what we're going back to, what you mentioned in 2013, is that we realized you can even get very profound vulvar swelling with arousal because of this venous insufficiency. Guess I have one more other component just in the EDS. I know I said I had a lot, and I do have
Yeah.
a lot. Um,
Yes.
you can get organ prolapse. So the bladder can fall down, the rectum can come up, and the uterus can fall down. All of these things are much more likely to happen and occur with people who have EDS hypermobility.
And before we move on to MCAS, if that's what we're gonna move on to, I did make a note about Tarlov cyst because I wanted to make sure we talked about that. That's how I found out that I had EDS. I had a sacral Tarlov cyst and had all kinds of problems from it, and ultimately had surgery for it. And my neurosurgeon, Dr. Frank Feigenbaum, I've interviewed him for this podcast. So we will link that episode also in the show notes so people can learn more about Tarlov cyst, because that's something that I find so frustrating. People will get imaging done, and I don't know if you find this, but I find it so common where the radiologist might not even comment on the Tarlov cysts at all because, as far as they're concerned, they're an incidental finding. And if they do, they often put it in the findings, but not in the impression. And so oftentimes the patient is only told what the impression was. And if they don't actually go and look at the report, they may or may not know about that extra
I
piece
mean,
of information. Yeah.
I always specifically to the radiologist when I'm giving my, I don't just write lumbar MRI. I say
Hmm.
lumbar MRI rule out herniated discs,
Hmm.
annular tears, and Tarlov cysts. Now,
Hmm.
they often will not even will ignore annular tears as well. So, an annular tear for your viewers is, if you look at the discs between the vertebrae and the spine, the discs are sort of like jelly donuts. They've got a tough outer core, and in the middle they have this liquid that acts as a shock absorber. Now, what can happen is that outer core can tear, and that this liquid can seep out, just like a jelly coming out of a jelly donut. And that can be that liquid can be very irritating to the nerve roots. So a very small annular tear can profound neurologic symptoms, and radiologists often won't even mention them.
Hmm.
So it's very important. So that's when I ask for these specific imaging studies, it's really important to tell the radiologist what you should look for.
Hmm. Yeah, no, that's a really good point. We have a fair number of medical professionals that listen to this podcast, so every little, pointer like that is much appreciated. So, thank you.
And also, I guess I would say make sure you get as good a MRI machine as possible. I think you'd almost always want a 3 Tesla machine as opposed to 1.5 Tesla. You really need good visualization and good resolution to see some of these small annular tears.
Sure, and that's something that, you probably know local to you where to refer your patients to, but if patients are listening to this, is that something that they can call the imaging center and ask, what the
Just say,
magnet.
or is your machine a 3T or 3 Tesla machine?
Mhm. Okay.
Not the car. That's the strength of the magnet.
Right, right.
So at least for right now, these are the ones I can think about that, uh, oh, one more, I lied.
Okay.
Herniations. So,
Mm,
hernias can be a profound cause of pelvic pain. And people who have EDS can have many hernias. I've had patients who have 13 or 14 different
mm,
abdominal wall, obturator internus hernias, and these hernias can cause pain. They're very often can be very insidious pain. You can't figure out where it is. Because it's not just the pudendal nerve, but their genital femoral nerve, ilioinguinal nerves. All of these nerves can also be obturator nerve. All of these nerves can be irritated if there's a hernia there as well. So good imaging, but not just good imaging, but it's really um, an awareness that these things may be the issues. Because no one's gonna, unfortunately, there's no one who's gonna go, the radiologist is gonna say, "Well, this may be the cause of your pain," or the general surgeon may not know that these hernias may be the cause of the pain. So you really have to have a very good understanding of all the potential causes of the pain, and so you can figure out what it is. And then it's so peeling away layers of an onion. It's often a lot of nerve blocks to figure out, injecting some anesthetic in these areas and say, okay, does the pain go away or not? Even if it just goes away for an hour or two, but that's where it is. And so we do rely I rely a lot on, either physiatrists or interventional radiologists, to do nerve blocks with me, to help figure out the location of the pain. Because unfortunately, a lot of people have more than one of these things. If they have EDS or hypermobility, they will have the herniated discs, and they will have the labral tears, and they'll have the um, Tarlov cysts. And then you're like, okay, now that we have all these possibilities, what can you do? The other way we can try to figure this out besides nerve blocks is something called neurogenital testing. And so we're looking at nerve conduction, not just going down to the vulva and the perineum but you're also looking at nerves going down to the legs, feet, and if there's abnormal nerve conduction going to both the vulva, the perineum, as well as down the legs, then it's more likely that the nerves are being impinged upon in the spine. However, if you just have it going on one of those two things, it's more likely to be more peripheral than the spine. So we're always trying to triangulate, as to where the potential problem is.
Is that testing that you do in your office, or, do you
That's
refer them
something
to
I
okay.
Yeah, I have that in my office. Another colleague by the name of Erwin Goldstein, no relation. We've written 9 books together, or not, I don't know, 5 books together, but no relation. Erwin Goldstein's on the other coast. He's in San Diego, and he also does neurogenital testing. To my knowledge, we're really the only 2 people in the U.S. who are doing it.
And I've also interviewed him for the podcast, so,
There you go. There you
and I
go.
was wondering if you were related, to be honest.
Nope.
So,
No.
I
It makes it a
appreciate
bit
you.
more complicated. He has a son, Andrew. So, um,
No way. Oh my
yeah.
gosh. That's funny,
Um,
that's funny. So, I will link that episode as well, because we covered very different topics, but, people listening to this are probably gonna be interested in listening to that episode as well. You both have done such amazing work. Okay, that's great information. So, okay, so should we move on to MCAS, or were
the
there other
MCAS, sure.
okay.
Yeah. So mast cells are, I guess, the evil white blood cell. And obviously they have a huge role in inflammation. And So one of the more common causes of vulvodynia or vulvar pain is something called neuroproliferation. And neuroproliferation is when you get too many nerve endings in the tissue. And the reason you get too many nerve endings in the tissue, one way, is because of a severe allergic reaction or a severe chronic infection.
Mm,
And these things are mediated by mast cells. And mast cells, in all their glory, will, if they stay activated, will secrete something called nerve growth factor. And nerve growth factor actually causes or allows the sprouting of new nerve endings. And you can get a huge increase in the number of nerve endings. Unfortunately, the type of nerve endings that grow are called C afferent nociceptors, and those nerve endings are responsible for the sensations of burning, rawness, and
mm,
cutting.
mm,
So you can get a huge increase in density of nerve endings. To make matters even worse, these mast cells will secrete something called heparinase. Heparinase allows those nerve endings to actually pierce the bottom layer of the skin. So nerve endings are supposed to stop at what is known as the basement membrane, which is the bottommost layer of the skin, and it's actually what separates the skin from the fat. So the nerve endings should stop here. But what
mm,
happens is now you have all these new nerve endings and they're growing and growing and growing, even way, so now you have too many nerve endings, and now they're too superficial.
Mm.
And so so you get this condition called neuroproliferative vestibulodynia. It's a mouthful, but basically they have too many nerve endings in the entrance of the vagina called the vestibule, and so they have profound pain um, uh, uh, at penetration, at attempted penetration during either tampon insertion or intercourse, or just even when there's pressure applied to the area with underwear or leggings. So mast cells can cause some people who have mast cell activation can cause that. Additionally, a similar condition in the bladder called interstitial cystitis painful bladder syndrome is also mast cell mediated. So you get a severe chronic inflammation and irritation of the bladder lining, again, mast cell mediated. And that can happen. It can happen, for example, if someone has a long term urinary tract infection, and they can get hypersensitized to even things such as caffeine or alcohol or citrus or acid in the urine. So that's another profound way that mast cells cause pelvic pain.
Mhm.
Additionally, there's a condition called endometriosis, in which the lining of the uterus, the endometrium, grows outside the uterine cavity, but out in the pelvic cavity, and that can cause profound pain, very painful periods. It can cause scarring. It can lead to infertility. Um, and that, if you actually biopsy the lesions with it that shows the endometriosis, not only do you have the endometrium, that abnormal that's supposed to be just in the lining of the uterus, but you also have too many mast cells and you have too many nerve endings. So it's the same pathology, whether it's endometriosis or neuroproliferative vestibulodynia or interstitial cystitis painful bladder syndrome. So all of these things. Now, we also recognize that IBS often can be mast cell linked,
Mhm.
as is SIBO. And when you have chronic abdominal pain because of GI related issues, that can also lead to chronic pelvic pain. So, the the bad actors, these mast cells are really a big, big, big player when it comes to pelvic pain. Aside from, again, the hypermobility components that we just talked about.
So you're finding that people who have SIBO or small intestinal bacterial overgrowth, in addition to having abdominal pain from that pelvic pain is also a common finding?
Yes.
Interesting.
And again, but it may be not just the SIBO itself, but it's because they have mast cell activation, and
Mhm.
therefore they can have these other problems as well.
Mhm. Yeah, and we know that people with these problems are well, and we didn't even talk about POTS yet, or
No, we're gonna
which
get
is
there. Yeah,
which is
yeah.
of course one of the forms of dysautonomia.
Hmm.
So this is, I think, the other thing that's so um, frustrating for people is so many of these things have such overlap and can cause
Hmm.
all three of those things, right? Can contribute to your risk of something like SIBO. So it's really a complex situation pretty quickly. So. Are there some things that we need to be aware of then with dysautonomia, which again, we know POTS or postural orthostatic tachycardia syndrome is one of the things that we might want to consider. One of the categories or one of the diagnoses that fall under the category of dysautonomia or dysfunction of the autonomic nervous system.
So yes. So, and yeah, again, sort of, I guess the terrible triad of dysautonomia does also cause pelvic pain. So, not only is the pudendal nerve going to the vulva and vagina, there's the pelvic nerve, and the pelvic nerve are the autonomic nerves that go to the uterus, the
Mhm.
cervix, and all of the glands of the vulva and vagina. And so, if you have dysautonomia, you can actually have pain associated with this autonomia as well. So you can have glandular dysfunction as well as deeper pelvic pain because so it's less of what we call somatic pain. So you can't exactly put your finger and say it hurts
Mhm.
right here. It's
Mhm.
just a diffuse unpleasantness, and it can be a profound unpleasantness. And often that's attributed purely to endometriosis. And then people say, okay, if you don't have endometriosis, we don't know what's causing your pelvic pain.
Mhm.
But often it could be related to the pelvic nerve. And so the dysautonomia is another component of this triad that leads to some role in pelvic pain.
Okay. Well, we are going to take a quick break. And when we come back, we're going to talk about treatment options, prognosis, some of the different things that Dr. Goldstein has found most effective. So we are going to take a quick break and we'll be right back. This episode of the Bendy Bodies podcast is brought to you by EDS Guardians, paying it forward in the Ehlers-Danlos Syndrome's community, patient to patient for the common good. I am proud to serve on the inaugural board of directors for EDS Guardians, a small charity with a big mission and a big heart. Now seeking donors, volunteers, and partners. Patient advocacy and support programs available now. Travel grants launching in 2025. Learn more, shop for a cause at their swag store, and join the revolution at edsguardians.org. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, we're back with Dr. Goldstein. So, can you start out now by telling us, in terms of resources, obviously you have your practice, and I know, like you said, it's a little confusing. Dr. Irwin Goldstein is on the other coast, is in San Diego, but not everyone can get to you or to him. What resources are there for women to figure out what the cause is of their pelvic pain or their pain with sex?
Well, actually, together we did write a book, Erwin and I, called "When Sex Hurts," and it's actually in the second edition was released just about a year ago. 100% of the proceeds of that book go to the National Vulvodynia Association.
Mm,
So we've never made a nickel on this stuff. It all goes 100% to the National Vulvodynia Association. So that's available on Amazon, called When Sex Hurts.
hmm
It's really one of the best things I've done because I really do think it's a really good resource.
hmm
Um, uh, I guess I would say that if there's any deficiency in the book, it doesn't talk enough about EDS. It certainly mentions it and hypermobility, but even when we wrote this 18 months ago, I guess um, I just didn't understand in a weird way, the richness and
hmm
that this triad affects pelvic pain. I think I realize more and more every day. Um, so that's one resource. We do have a textbook for professionals,
mm
called Female Sexual Pain Disorders, and the second edition of that came out a few years ago as well. And 100% of those proceeds um, are donated to the International Society for the Study of Women's Sexual Health, or
mm.
ISHWISH.
Wow.
So those are some resources, online resources. I have a website called vulvodynia.com,
hmm
and there's a lot of resources. We all our published work goes on that website, and so that's quite useful. And resources to help find patients. Um, uh, the ISHWISH, the International Society for the Study of Women's Sexual Health, so ishwish.org, has a lot of information for patients as well as find a provider,
hmm
way to find people if you look for someone who's an Ishwish fellow, they've certainly heard about this stuff before. They may not be experts, but they're certainly trying to become experts and care about this. Um, so those are probably the biggest resources. I probably will think of a couple others in a few minutes, but those are some good places to start.
Great. And I actually just spoke at the Ishwish conference. It was my first Ishwish conference. So
Oh,
it was
okay.
really fun in Atlanta last month, a couple months ago.
Hmm.
And what a great organization. And that's wonderful that you've published these books and are donating 100% of the proceeds, because writing a book is just an incredible amount of work. So that's amazing that you've done that. So yeah, those are great resources, and we'll be sure to link all of those things in the show notes so people can find them really easily. One thing that a lot of people have been referred to, including myself, as someone who has the at least some component of each thing of the triad to some degree, a lot of us have been referred to pelvic floor physical therapy. And for me, I found it super, super helpful, but I know some people have not found it as helpful. Do you have any thoughts as to why it's sometimes not as helpful as other times?
Absolutely. So, a couple of things. First of all, when muscles are hypertonic, they're not just tight, they're tight and short.
Mm,
Okay. And again, that leads to a profound decrease in blood flow. Just a 10% increase in muscle tone will cause a decrease in blood flow of 50%.
mm,
Again, that profound decrease in blood flow causes decrease in oxygen, hypoxia, lack of oxygen. And it's not just actually the buildup of lactic acid. There's something called hypoxic inflammatory response. So actually decrease in oxygen leads to inflammation as well, which also activates your mast cells, of course, to make things worse. Okay, so the muscles are not just tight, they're tight and short. The
mhm,
only way to get blood flow back to the muscles and therefore oxygen back to the muscles is two things have to happen. The muscles have to both relax and get back to their normal length.
mm,
The problem is that if you just go to physical therapy, what they're doing is they're stretching a tight muscle. It's stretching a rubber band. And all so what will happen is people may get loose during physical therapy, but by the time they're back next week, they're tight again because we didn't help the physical therapist. We
mhm,
really need to help the physical therapist by relaxing the muscles. And the way I do that, the two main types of muscle relaxants I use are suppositories of something called diazepam, which is Valium.
mhm,
Sometimes if people can't tolerate it, we use a muscle relaxant called baclofen, although I feel that the diazepam works better.
mhm,
But the big gun, the thing that works really the best is botulinum toxin injections, so Botox
mm,
injections, or any type of Dysport um, or, uh, or other, Juvo, it doesn't matter which toxin
mhm,
you which name brand, but basically, botulinum toxin injections, if done correctly, the right dose, really can, profoundly help a pelvic floor physical therapist. So that's number one. That's it. That's one reason why sort of pelvic floor physical therapy fails is we're not helping the pelvic floor physical therapist. The second thing is that it often fails is because they're not addressing the structural problems. So you may have a leg length discrepancy, or they really often, miss the labral tears. Um, they don't have a strong ortho background, the physical therapist, or I'm just not thinking because again, if someone's not complaining of real bad hip pain, people
mhm.
may not be looking for it.
Sure.
So structural problems, SI joint instability,
Mhm,
um, uh, again, so common with EDS. If these aren't addressed, then it's two steps forward, one and 7 steps back.
mhm,
So, so that's that. Uh, there is, obviously we've come a long, long, long way when it comes to pelvic floor physiotherapy. I mean, 25 years ago, there were, maybe a city would have one or two
mhm,
people. Now, I work in New York City, there probably 150 or 200 pelvic
mm,
floor physiotherapists, physical therapists, but there's sort of a wide range and experience levels
mhm,
and so that may often people say, well, I went to pelvic floor physical therapy, and I'll say, well, how much like internal work they do? Oh, they never did internal work,
mhm,
so or they maybe did 5 minutes on the first evaluation and that was it, type of things like that. So there's a
mhm,
range of sort of of experience levels with pelvic floor physical therapy. So I guess that those are some of the reasons why physical therapy doesn't work, even though it's sort of the right thing to do.
Mhm, mhm. And when it comes to doing Botox or, some other, neurotoxin, and you're relaxing the muscles, what about if the person does have hip instability or SI joint instability? Um, are you potentially putting them at risk of more instability then if the pelvic floor is kind of trying to hold on and keep that pelvis stable?
So again, you have to be very localized as to which
Mhm,
muscles you're doing. You're not
mhm,
do a global. So I actually, especially with hip instability, I'll stay far away from the obturator internus,
mhm,
unless of course that they have pudendal nerve pain, because then you actually do want to um, uh, you do want to relax the obturator internus so that their pain can go away. But then with the understanding that they really going to have to stabilize their hips somehow,
mhm,
whether that be physical therapy or even surgery if necessary. Um, but you're the benefit of these toxins are that they stay where you inject them. There's not much
mhm,
bleeding. So if I'm worried about pain, let's say pain with intercourse, pain upon penetration, I can really localize the muscles right at the entrance, right,
mm,
that are causing pain, and not cause instability of the whole pelvic floor.
mhm. Okay. And if somebody's going to a pelvic floor physical therapist who says, I can do dry needling in that area, because of course they can't inject Botox or anything like that. But um, what is your opinion about doing dry needling of the pelvic floor?
Well, I mean, dry needling and even trigger point injections are they're okay. The muscles will they will relax for a day or two
Hmm.
or some. You know, nice thing about botulinum toxin, it lasts 3 or 4 months.
Hmm.
So, I mean, if you're getting a needle in something, I would rather it last 3 or 4 months than, 3 or 4 days.
Hmm.
There is a cost factor to it and some insurances will not cover it. But there is it has I've actually, been doing botulinum toxin injections of the pelvic floor since, 2004. So
Oh, wow. Wow.
I've injected more than 1,500 women, and it is really, if I had to give that up, I would probably, I don't know if I could practice medicine,
Wow.
because it's a key tool in my tool belt,
Hmm.
um, for pelvic pain.
Okay. So, so that treatment versus dry needling, and then you can probably even go down one other level to do like myofascial release, but that's going to be probably even more short-lived, right? So that's maybe why some people have had that done on the pelvic floor, and it maybe just will give some relief for a period of a few hours if you're lucky.
Right. I mean, again, but the thing about the myofascial release, though, is that it is lengthening the muscle, so that is sort of essential. But again, are you stretching a rubber band, or are you stretching a rubber band that you've cut so that it actually can sort of go out to get back to its normal functional length? I also do think that it's important. I understand strength is important, but depending on what, first you have to work on relaxation, because I think sometimes physical therapists jump into strengthening too quickly, and we got to relieve the pain first
Mhm. Yeah.
before we can regain function. We've got to actually get rid of pain. Um, and so I think sometimes physical therapists are, or people are limited that they only can have 8 sessions or 6 sessions, and so the desire to do so much all in a very short amount of time gets people to go, you know, steps A to D to F, without sort of getting B and C, which is get rid of the pain.
So you've mentioned, Botox as a treatment option, and then in some cases, for some people, maybe they do need surgical repair of a hernia or a labral tear in the hip or something like that. What other treatment options are possibilities for people? Of course, it depends on what the cause is, but what are some of the other things that you have found helpful in your practice?
I mean, nerve blocks can also be incredibly beneficial depending on where what if it's a true neurologic injury. So nerve blocks can be profoundly impactful in a very good way. Um, uh, we are doing a study right now on shockwave and how
Mm,
shockwave can augment pelvic floor physical therapy. It's a new modality. We know it's very safe. Anecdotally, there are many pelvic floor physical therapists who actually feel that it is quite beneficial.
mhm,
It does. I mean, we do know that shockwave does increase blood flow, cuts down inflammation. It also brings stem cells to the area.
mm.
So there really could be some really good regenerative and beneficial properties to shockwave. And so we're doing a clinical trial on that right now, to just augment pelvic floor physical therapy,
Mhm.
not to supplant pelvic floor physical therapy. Um, Other treatments, I mean, we do, again, I'm not a mast cell specialist, but I certainly understand that using both antihistamines, H1 and H2 blockers, as well as mast cell stabilizers, cromolyn sodium, montelukast, or Singulair, um, ketotifen, and other types of antihistamines are very important to cut down on inflammation throughout the whole body, especially if I do think it's a mast cell mediated process. And so I make liberal use of those as well.
And I found when I prescribe those to patients, sometimes they're not necessarily looking for this, but they do find an improvement in their bladder pain
Mhm.
or, their perineal pain of whatever sort it might be, pelvic pain. Have you ever tried or recommended that, somebody try using either cromolyn sodium or ketotifen, topically on the vulva?
I have not. Well, there was a study of cromolyn sodium, a topical preparation. The study was done by Paul Nergesi maybe 20 years ago.
Oh, wow.
It did not show benefit, but um, this was sort of in the early days of Vulvodynia research. So all Vulvodynia was this black box. So would it work if you didn't treat, if you sort of narrowed down the people who had more of an inflammatory vestibulodynia instead of a vestibulodynia because of hormonal factors or because of too many nerve endings. So I haven't, so I don't use it uh, typically topically. I actually tend to try to stay away from topical preparations because they can be very irritating. It sort of has there are other vulvar specialists out there who are compounding compounds of gabapentin and amitriptyline and ketamine um, and cromolyn and baclofen and throwing them all at people like the kitchen, like every all the tools of the kitchen, and all at one. And I've just found in general that those are incredibly irritating, and I have not found much success in these preparations. Others people have. I don't exactly know why I've failed and they've had success, but eh, in general, I try to, especially people who have such topical allergens. If people are dermatographic. I
Mhm,
stay away.
mhm,
Basic vulvar care measures are also just really important. People
mm,
are exposed to so many chemicals on the vulva,
mm,
um, and they don't realize it. Every soap, Dove soap, 99.44% pure has 12 different things in it. Toilet paper,
mm,
if it's soft and it smells good, that's not a trees are not soft and smell good.
Mhm.
That's just lots of chemicals. Um, so we really tell people to focus on hypoallergenic toilet paper, hypoallergenic menstrual pads, stay away from soaps. Um, uh, if you can, hand wash any type of clothing that will touch the vulva.
Mm.
I practice in New York City, and in New York City as other places, but New York City, people, an apartment building will share a washing machine or share several washing machines, and people say, "Well, I use my all free and clear, or I use my draft, and therefore I'm using hypoallergenic soap." But you're using the soap that the last 30 people also used in that washing machine.
Mhm.
So you really um, uh, really have to be careful about allergens and potential irritants. I find that there's sort of a profound um, increase in vulvar pain when people go off to college, and that's because
Mm.
they've had very sensitive skin, and but they've known their moms have known about it for a long time, and so they've sort of the laundry's all been done in one machine with sort of hypoallergenic, and then you all go off to a dormitory and you share the machine with 50 other of your classmates, and you get so irritated and itchy, and you'll use just any toilet paper or any soap that's lying around, and that can really cause some problems.
I feel like you just reported my whole childhood right right here, because my mother went through this process with me and figuring out, like, no, you just cannot. I had sensitivity to so many different things, and definitely have discovered over the years, kind of what you were saying about, uh, you know, chemical exposure, and also even simple things sometimes like tight pants, sitting for long periods of time, right? That can also increase the risk of having more problems.
Yeah, putting pressure on the pudendal nerves and things. Yep. So these are all, so it's complicated, I guess. The We're engineered with a lot of parts all in a very small area in the pelvis, and
Mhm.
so reproductive and defecatory and urinary, um, and our core stabilization, and so all of these things happen. Um, all in a very small area, and can get profoundly impacted by all the things we've talked about.
Okay. And a listener asked I asked some listener questions, and I have a couple that before we wrap up here that I wanted to try to get to. So the first person asked about the interaction between endometriosis and MCAS and EDS, and what are your thoughts on treatment for true diagnosed vestibulodynia for hypermobile folks if dermatologic conditions, hormone imbalance, yeast, etc., have all been ruled out, and the only findings are chronic inflammation and persistent pain? Is surgery, such as a vestibulectomy, really the best option? Do the high success rates of surgery apply to the hypermobile population? Does vulvar or vaginal tissue that is hypermobile heal well enough to tolerate tissue removal and recovery in this region?
Luckily, I actually think it does.
Mm.
I've looked at this, and have not found any significant difference in success rates in the vestibulectomies that I do, in people who have hypermobility. I mean, I was doing vestibulectomies for 15 plus years without even
Mm.
recognizing that people were hypermobile, and we had very good success rates back then. So I mean, that's good. It wasn't like we were. Um, but I'm very, and this is very important, I'm very, very, very selective as to
Mm.
who I do a vestibulectomy on.
Mhm.
It really has to be pain just localized to the vestibule. And it has to be pain throughout the entire vestibule, not just in the back part of the vestibule. And I am incredibly careful to make sure that people do not have components of pudendal neuralgia,
Mhm.
um, because all of these things will severely impact the success rates of the stimulectomy. Now, pelvic floor dysfunction itself does not um, um, impact the success of the stimulectomy. It just needs to be addressed after. the surgery is recovered. So it realized that the vestibulectomy is not necessarily the end of the journey. It's the
Mm,
biggest mountain to overcome, but it doesn't mean that right on your when you fix, that have recovered for that. That means you're perfect and you're going to be okay. I always talk about my surgical successes at a year, because often we have
mhm.
things that we need to do after the surgery is completely healed. But people do heal well with EDS from vestibulectomy if it's done well by someone who really has a lot of experience.
And we discussed vestibulectomy also with Dr. Irwin Goldstein, but I probably should have prefaced this by you described earlier what the vestibule is, but I think this is something, especially without, we're recording this audio and video right now, but we're not showing like any slides or anything. Maybe we can find one to insert right here. But can you explain again what the vestibule is so that people, and also what a vestibulectomy is?
Sure. So the vestibule is the rim of tissue that's right at the entrance of the vagina. So it's inside the labia minor, or the small lips, and it's outside the hymenal ring. So it's
Mm,
just about this far in, so about an inch in, right at the center. And the urethra goes right into the center of this tissue. So it's
mm,
a horseshoe-shaped area of tissue. It's the amount of tissue basically that's on the back of your thumb, so about 2 square centimeters, or think of a postage stamp.
mhm,
Um, but the amount of postage stamp, but that's basically a or horseshoe, and it's very unique tissue. It's different embryologically than the rest of the vulva or vagina, and it acts differently hormonally, and it reacts differently to any allergic or infectious insults. So that's why the majority of people who have vulvodynia or vulvar pain actually have vestibulodynia, which is just pain
mm,
confined to the vestibule.
mm,
A vestibulectomy is to remove the top layer of this skin of the vestibule, about 3 millimeters deep. Or if you think about 3 millimeters, think about like 10 sheets of paper together, and that's about 3 millimeters. So you're taking off this top layer, very thin layer, and in that top 3 millimeters are where all those nerve endings are.
mhm,
And so you're just removing that top layer and then replacing that top layer with tissue that comes from the vagina. So
mm,
we actually pull the vagina down, much like we're stretching a turtleneck. I always say just like this. We're
mhm.
stretching it about this far, about a centimeter and a half, to replace the area that we removed. Um, I've been doing them. I was taught how to do a vestibulectomy by my mentor, a man named Stan Marinoff, who um, uh, he had done about 300 of them, uh, and I have done over close to 1,300 of these procedures over the last
Wow,
27 years.
wow.
But it's still, I used to do a lot more. I used to do many more, because we didn't really have much treatment. We way back when, again, it was a black box, and sort of the only thing we knew was to cut out some tissue. But now, when we've been able to figure out who's having inflammation, and who has hormonal component, and who has all these other things, we're doing many, many less vestibulectomies.
And what are outcomes like at that year mark, would you say?
So now I'm gonna give you my numbers, and I have to say that
Sure.
I don't think I can really give you uh, the numbers for just anyone out there. I will tell you that we've contacted over 200 women at least a year after surgery, and there's a 97% patient satisfaction rate.
Wow.
So it's sort of the Yelp success rate. So basically, and these are independent researchers. It's not us saying, it's not me asking them, did you get better? But it's really independent researchers. And so we ask women, knowing the results of your surgery and the discomforts of your surgery, would you do it again? And would you recommend it to another woman with similar complaints? And 97% of women say they would do it again and would recommend surgery. So that's
Wow.
incredibly high. But again, I'm very, very cautious as to who I do surgery on. Now, 1 year after surgery, 58% of women have no pain with intercourse, zero pain with intercourse, provided they use a lubricant if necessary. An additional 30% of women have minimal discomfort, but you can't say zero discomfort. So that's 88% of people have minimal or zero pain with intercourse. Um, and even of those 12% left, still three-quarters of those women, or 9 out of the 12%, are very happy that they had surgery because their pain is still only mild to moderate, and it's nowhere near as bad. So again, the vast, vast majority of people that we do a vestibulectomy on are very, very happy they had surgery. Now, I will say that only 7% of my patients who walk into my office in a year are vestibulectomy candidates.
Sure.
So I evaluate over 500 new pelvic pain, vulvar pain patients a year, and I really am doing, less, far less than 40 vestibulectomies a year. So about 7% of people are candidates, and so I'm very um, so I think the success rates are based on we really are a technique, but
Mhm.
the success of surgery is made even before you walk into the operating room, which is knowing who you should operate on.
Yeah, absolutely. I'm married to a urologist, by the way, and, yeah,
Yeah.
patient selection is everything, so
Yes, yeah, the
definitely.
success of again is made before you walk, or you
Yeah.
certainly you're the failure can be made before you walk into the operating room if you're
Mhm.
operating on the wrong person. First do no harm. And so
Right.
I'm very selective. I'm um, uh, very cautious to really make sure. Now, that's not to say that you have to try 20 other things first.
Mhm.
I disagree with that. That vestibulectomy is the last resort. It is not.
Mm.
It can be the first treatment of if it's the correct diagnosis.
Mhm.
But
Sure.
so it's really all about the correct diagnosis for a vestibulectomy is something called neuroproliferative vestibulodynia, only having too many nerve endings.
Mhm.
And if you have pain only in the back part of the vestibule, that's not the cause of your pain.
Mhm.
So I find that a lot of people have had vestibulectomies for the wrong reason, and they still have pain because the pain in the back part is where the muscles attach,
Mm.
and so you can still get rid of the mucosa on top, and you're still having pain because the muscles are still hypertonic underneath.
Right. Okay. And I wanna ask one other quick listener question before we wrap up, and this person asked about lichen sclerosus and lichen planus, and I don't know if I pronounced that right or not,
Yep, yep.
and how you
Uh-huh.
can tell the difference and what to do if standard steroids don't work.
So, lichen sclerosus and lichen planus are both autoimmune inflammatory skin diseases of the vulva. The difference between so um, I would say they're closer than cousins. They're
Mm.
half siblings. The difference and to make things even matters more complicated, they can coexist.
Mm.
One of the ways to know the real difference, though, is that lichen sclerosus does not go in the vagina, whereas lichen planus does.
Mm.
Um, Lichen planus usually causes more erosions, which is sort of the skin being eaten away, as
Mm.
opposed to lichen sclerosus, which is actually a thickening. Lichen means thick
Mm.
and scaly.
Mhm.
So there is nuance to them both. Now,
Mhm.
um, if they don't respond to steroids, so so first of all, I will say that the majority of people who don't respond to steroids, it's not that the steroid is not working; it's that they're not actually taught how to use the steroids.
Mm.
So often they're just said, "Okay, here's a tube, go use it."
Mhm.
Um, I have the same tennis racket as Roger Federer, but he gets a little better results than I do because he knows how to use that tennis racket just a little bit better than I do, and so I actually think that people aren't taught how to use steroids. So the most important thing with steroids is number one, you want to soak in warm water first to soften the skin,
Mm.
and then you've got to rub the steroid into the skin really well, because the layer of inflammatory cells is at that bottom layer of the skin at the basement membrane. If you just sort of just do this, it's going to do absolutely nothing. So that's
Mhm.
number one. Now, also people can be allergic not to the steroid component, but they can be allergic to the vehicle.
Mhm.
So there are preservatives in these steroids. So sometimes you need to compound the steroids in a base that's non allergenic for that person. Some other subtle nuances: the lichen planus tends to um, respond better to things called the calcineurin inhibitors
Mm.
than because steroids inhibit collagen formation, and pardon me, they inhibit collagen formation. And in the case of lichen sclerosus, you sort of want to do that. You do want to, the skin is actually hyper thick, very thick. So you do want to actually thin the skin a little bit. But in the case of lichen planus, where it's eroded, you actually need new skin to grow.
Mm.
So the calcineurin inhibitors, which is tacrolimus and pimecrolimus, don't inhibit collagen formation. So they tend to work a little better. And then lastly, we are doing some very big starting some very good clinical trials on a completely different type of medication for lichen sclerosus, and that does probably work also for lichen planus, which are called JAK inhibitors or
Mm.
Janus
Mhm.
kinase inhibitors.
Mhm.
We did a study 3 years or 4 years ago now where we biopsied um, the affected skin, or the sclerotic skin, and then we biopsied adjacent normal skin, and we looked at the different in RNAs between the two. So basically, we could tell which genes were turned on and off between the normal skin and the skin that was affected. And in doing so, we were able to find the very specific inflammatory pathway that's affected in lichen sclerosus. And that inflammatory pathway is called the JAK-STAT pathway. Regardless of that, you don't have to know that, but what's important is that the JAK inhibitors it makes very plausible sense that JAK inhibitors will work for this disease. Steroids are much more like a carpet bomb approach to the
Mhm.
treatment of inflammatory disease, where a JAK inhibitor is a much more laser focused
Mhm.
approach to the treatment. So there are things that, so to your viewer, please don't go out and start asking for JAK inhibitors or things like this. We don't have the data. We don't have the to recommend these things. But I just mention these things is because we're constantly getting better at treating these
Mhm.
things. The center where the center I run, the Center for Vulvovaginal Disorders. Again, we constantly are doing research on all of these things. We every few years there's some profoundly important improvement and discovery that we are making that really leads to new and better treatments for women with vulvar pain, pelvic pain. So even if you saw someone 10 years ago or 15 years ago and didn't get help, please don't say that I tried that and I'm done.
Mhm.
We constantly have new tools added to our tool belt to help women. That's not to say that we can use tons more, but I guess I could end by saying, when I started this 25 years ago, we probably got 50% of our patients 50% better.
Mm.
But I'm sort of proud to say now, 25 plus years later, we're probably getting 85% of our patients at least 85% better.
Wow.
So I think we've made a profound impact, but there's still room to go.
And I would actually say that even if they have seen somebody much more recently than that, if you go to a gynecologist, OB-GYN who is doing, deliveries of babies and managing, all the different conditions that can happen and doing tubal ligations and all these different things that they're not specializing like you are, they might not be aware of the different treatments that are available. So one of the reasons why I feel like the podcast is so important is it brings this information to people, makes it accessible so that they can, even if they can't come out and see you, at least they can maybe try to ask for some of these things and or share this episode with their GYN and say, hey, would you be willing to listen to this or read the transcript or whatever? Because the JAK inhibitors, that's interesting because those are used also in mast cell activation syndrome.
First, yeah.
So yeah, so many connections, of course. So this is just fantastic information, and I'm so grateful to you. Before we wrap up, the last question that I always ask is for a hypermobility hack. So do you have a hack that you can share with us?
Uh, I think you probably asked me to come up with one. And I forgot if I came up with one or not. I guess it's just important. So I guess the the one hack is that don't ignore the hips.
Hmm.
I think that this is uh, the overlooked so much, even by healthcare physical therapists. The role of the hips and labrum in vulvar and pelvic pain uh, uh, is a key, and so that's really, I guess, important because that I think that this is it's not addressed, or they'll or my I know I have a labral tear, but my orthopedic surgeon said it's fine. Whatever certainly doesn't know the connection between this and why I have chronic rectal pain and I can't sit for 10 minutes.
Hmm.
And so don't overlook the hips. That's my hack.
Okay. And you gave us lots of hacks, but I always like to end with one special hack. So wonderful. Can you let us know where people can find more about your incredible work and if you have any special projects or research that you want to share with us?
Again, where you can find a lot of information, plus our practice is vulvodynia.com.
Hmm.
And again, I do recommend if you can come see us, and I certainly understand people can't all come to New York City or Washington, D.C., that the books When Sex Hurts and Female Sexual Pain Disorders are quite beneficial. So those are one things. And I guess lastly, if you uh, what I do in my free time is I do a lot of cervical cancer screening
Mm.
in resource poor countries, and so if you care about women's health in resource poor countries, and have recognized that a lot of the uh, aid to these countries has been dramatically cut in the very recent months. If you care about that, if you went to our website, gyncancers.org, GYN cancers.org. I'm sorry, GYN cancer, I'm sorry, .org, not what they asked. That, that, that you could certainly help uh, our treatment of women in resource poor countries who are dying of cervical cancer. With
Mm.
if a woman is screened one time in her life, we would reduce her chances of dying of cervical cancer by 70%. So
Wow.
that's my
Wow.
that's my for pitch on that as far as that goes.
Okay. Well, we'll definitely share that as well. Thank you so much for taking so much time to chat with me today and share this wonderful information. And I just think it's so important for people to know that there are things that you can do. So many of us are told, you know, we don't have anything for you, and it's so frustrating. And I feel like this is just a conversation that's going to really help a lot of people. So I'm just so appreciative of your time today.
Well, thanks for having me. Again, I'm glad we could get this information out there.
I've really enjoyed this conversation today with Dr. Andrew Goldstein. I feel like it's so important for women to know what they can do in order to improve their pelvic pain and their perineal pain. And this is such a common problem. So many women are suffering needlessly. So I hope you found this episode helpful. I know I did. I really want to thank you for listening to this week's episode of the Bendy Bodies with the Hypermobility MD podcast. You can help us spread the word about joint hypermobility and related disorders by leaving a review and sharing the podcast. This really helps raise awareness about these complex conditions. If you would like to dig deeper, you can meet with me one-on-one. Please check out the available options on the services page of my website at hypermobilitymd.com. You can also find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter or LinkedIn at Hypermobility MD. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can also find full video episodes up every week on YouTube at Bendy Bodies Podcast. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.